Thanks for the invitation. Those are my disclosures. And again, we are focusing on elderly patients or those with comorbidities in whom we know that single-agent ibrutinib or a combination chemoimmunotherapy chloramosil-based with anti-CD20 antibody represents an established recommended first-line treatment. The iLLUMINATE phase 3 study was designed to investigate whether the addition of obinutuzumab to single-agent ibrutinib would provide superior efficacy versus chloramosil obinutuzumab, which is considered the standard of care of treatment at that time. And iLLUMINATE was the first study to prospectively evaluate a chemotherapy-free regimen against chemoimmunotherapy, even in patients with high-risk genomic features. Eligible patients were 65 years or older or under 65 years with at least one coexisting condition and were randomized to receive ibrutinib until progressive disease or unacceptable toxicity in combination with 6 infusions of obinutuzumab. The other arm was represented by chloramosil obinutuzumab given for 6 cycles. Patients randomized to receive chloramosil obinutuzumab were allowed to cross over to receive ibrutinib as salvage treatment after IRC confirmed progressive disease. Patients and disease characteristics were well balanced between the 2 arm groups, and we can focus here. We had 65% in each arm of patients with high-risk features, defined the high-risk population as having at least one among unmutated HHV, 11q deletion, 70p deletion, or TP53 mutation. After a median follow-up of 31 months, significant progression-free survival was seen with ibrutinib obinutuzumab compared to chloramosil obinutuzumab in the intention-to-treat population, with a median progression-free survival reached for chloramosil obinutuzumab at 19 months, and none reached in patients treated with ibrutinib obinutuzumab. The estimated 30 months progression-free survival was 79% versus 31%, and this superior progression-free survival benefit was also observed in patients with high-risk genomic features. Similar reduction in risk of progression or death was seen after excluding patients with 70p deletion, both in considering the intention-to-treat population or the high-risk population, excluding 70p deleted patients from the analysis, with a 74% or 84% risk reduction of risk of progression or death. The progression-free survival benefit with ibrutinib obinutuzumab was seen in all subgroups if you consider patients' characteristics and disease characteristics. And if we focus on some specific subgroups, we can see that the median progression-free survival was not achieved with ibrutinib obinutuzumab in patients with bulky disease, while was achieved with chloramosil obinutuzumab at 15 months. And the same applies if you consider the high-risk features, unmutated HHV, 11q deletion, and 70p deletion. And furthermore, among patients with unmutated IGHV, ibrutinib obinutuzumab was associated with an 85% reduction in risk of progression or death if patients with 70p deletion were excluded from the analysis. Ibrutinib obinutuzumab improved overall response rate and complete remission rate, and this both in RC and investigator assessment. And the higher and significant overall remission rate and complete remission rate were also observed in patients with high-risk features. Even the rate of undetectable MRD was higher after ibrutinib obinutuzumab when compared to chloramosil obinutuzumab, and this was true both in the peripheral blood and in bone marrow, and this was also true in the high-risk population group. Median overall survival has not been reached in the 2 arms, and the estimated 30 months overall survival is very similar, 86% versus 85%, but we have to point out that 40% of patients cross over to receive ibrutinib, and those patients were not censored from the analysis. Ibrutinib significantly prolonged time to next treatment, and only 4 patients enrolled in the ibrutinib obinutuzumab arm went on to receive a subsequent treatment when compared to 44% of patients in the chlorambucil obinutuzumab arm. As we said, we had a median follow-up of 31 months, and 70% of patients are continuing on ibrutinib. And the primary reason for treatment discontinuation were disease progression in both arms. The median duration of treatment exposure is 6 times approximately longer in patients receiving ibrutinib obinutuzumab. Consistent with this, the adverse event collecting period is longer for patients treated with ibrutinib obinutuzumab when compared to chlorambucil obinutuzumab, as we have seen in all other studies. It's 29 months versus 5 months. If you consider the grade 3 or higher adverse events, the rate is very similar. Most common were neutropenia of grade 3 or higher and infusion-related reactions in patients treated with chlorambucil obinutuzumab, and most common in patients treated with ibrutinib obinutuzumab, grade 3 or higher adverse events were thrombocytopenia and atrial fibrillation. If we look at the time-matched analysis of adverse events during the first 6 months of treatment, we can see that grade 3 or higher adverse events were lower in patients treated with ibrutinib obinutuzumab, and were lower and less serious infusion-related reactions. In conclusion, we can say that ibrutinib obinutuzumab provided a prolonged progression-free survival with a 77% reduction in risk of progression or death, and this was also true in patients with high-risk genomic features. There was a consistent benefit across all subgroups, and the safety profile of the combination was consistent with the adverse events that we would expect with individual agents. So ibrutinib obinutuzumab together with single-agent ibrutinib may provide another chemo-free option for our patients to achieve a prolonged progression-free survival. You will see on the poster the follow-up of the study up to 4 years that will be presented by Carol Moreno this evening. I would like to thank all the patients who participated in the study, the supportive families, of course the investigators and all the staff of the centers, and I would like to thank you for your attention.
Questions? Professor Halleck?
I've got one question, and that is on behalf of the 3 trials that we've now seen, these most important trials on ibrutinib. One of the puzzles that we come out with after seeing these updated data is, why do we see have a suggestion to see survival differences in the fit young patients and not in the unfit elderly patients? And despite the fact that in these unfit elderly patients we use weaker regimens such as BR or chlorambucil plus obinutuzumab, do you have any suggestion, or could it be that the toxicity of ibrutinib weighs in, therefore the conclusion could be ibrutinib is a drug for fit patients, which is the opposite of what I would have expected? What's your conclusion?
I believe that is also a matter of cause of death, and of course we have confounding factors with the elderly. We have more comorbidities. In the ECOG trial we had CLL-related deaths that we don't have mostly at least in the iLLUMINATE trial. So in the iLLUMINATE trial, deaths were not related to CLL, but we have confounding factors from comorbidities of patients, of course.
Question in the front.
I have a question regarding PFS in the chlorambucil obinutuzumab arm, because it's almost twice as short as in the CLL-11 trial. So how do you explain this difference?
The difference is that in the CLL-11 trial, CT scans were not performed regularly. In this trial, were performed every 4 months. And so you capture immediately the disease, the nodal disease progression in this case.
Professor Mulligan?
Alessandra, nice presentation up here. There's a very striking difference in the AF rate between the iLLUMINATE study and the Alliance study that we heard, so 5% versus 14 and 15%, 14 and 17%. You've quoted only grade 3, i.e. patients going into hospital and or with symptoms. Have you got the total AF rate, keeping in mind that all grades of AF have still got a stroke risk?
Was 7%.
Okay, thanks.
Thank you.
Thanks.